right, let's make sure that angle is good. All right, there we go. All right, good morning, everyone online. Thank you for joining us, and thank you to those of us who are joining us in person for our 2021 Health and Wellness Fair. My name is Kirsten Caleca. I'm the Director of Member Engagement here at the Reno+Sparks Chamber, and it's my pleasure to welcome you. We have a full slate of sessions today that we're so pleased to bring you. And the first is a panel discussion that's called The Truth About Weight. It's a topic that not a lot of us want to talk about, but it's something that, as we're seeing with the current health crisis that's underway, it's more vital to talk about it than ever. So we're going to have a robust discussion today. We're very much looking forward to it. And I'm going to turn things over now to our discussion moderator, Jonathan Delgado of Novo Nordisk, and invite him to kick off the session.
Sounds good. Thank you, Kirsten. And welcome everybody, at home dialing in to this first session entitled The Truth About Weight. It's really a panel discussion on weight management and obesity. And my name is Jonathan Delgado. I'm with Novo Nordisk. We're a global healthcare company really focused on discovering medicines to help people with chronic illnesses. We're certainly a proud partner of the Reno Chamber of Commerce. I'm joined today by a panel of local experts. I'm very, very excited. We're here to talk about something that really has become a growing problem, a healthcare crisis. One of the most prevalent chronic diseases really in the United States today, and that is obesity. It certainly has an impact from a health perspective, an economic perspective. And here in this state, in Nevada, we've got right around about a third of adult Nevadans living with obesity at this point. In Washoe County, in particular, we also have rates of childhood obesity that exceed those of the national averages. So I feel very fortunate to be moderating this discussion today with this panel, and we're going to talk about the impact of excess weight and what we as individuals and as a community and as employers, what we can do to really address it. So without further ado, I'm going to introduce our esteemed panel here. So starting with Dr. Kirsten Frederiksen. So she is an internal medicine and obesity medicine specialist in practice for over 20 years. With her expertise, she's founded 2 very successful weight management programs for large healthcare organizations. And her passion is in both improving individuals' health through weight loss, as well as the financial health of organizations through healthier, lower risk employees. And she'll be opening up a new medical weight management practice right here in Reno. Next, we have thank you for being here.
Thank you for having me.
Yeah. Next, we have Dr. Dana Trippi. She is the owner of Premier Physicians Weight Loss and Wellness. She completed her medical degree at Kansas City University of Medicine and Biosciences and a residency in emergency medicine at State University of New York at Buffalo. And emergency medicine was really what fueled her passion for obesity medicine. And she completed her board certification through the American Board of Obesity Medicine in 2009. And Dr. Trippi is dedicated to providing excellent care in obesity medicine by promoting education of the disease, which is what we're here to do today. And she operates offices really across the state of Nevada at this point. So very excited to have you.
Thank you. Thank you.
Yeah. And last but not least, we have Justen Caleca. Justen is a pharmacist and medical account associate director with Novo Nordisk. And in this role, he collaborates with leaders within the medical community, exchanging scientific data and discussing scientific interests and activities within the cardiometabolic environment. That includes diabetes, obesity, and cardiovascular disease. He received his undergraduate degree with a major in physiological science from UCLA and his doctor of pharmacy from the University of Pacific. So the Pacific. So thank you, Justen, for being here as well. So we're going to get into the discussion. Following the discussion, we'll hopefully have some time for some Q&A, but hold your questions until then, and we'll go ahead and get started. So I thought, a good place to start, we all kind of know that, excess weight and obesity has an impact on our health, right? But I thought a great place to start was to really define, from a health perspective, what exactly is the impact of excess weight, and really how are we addressing this issue? And I wanted to start with Dr. Trippi with that question.
Yes, thank you. Weight is just a number, right? But excess weight, actually, it's a number that matters. And it matters for a ton of reasons. It matters because it's a proven health hazard. It's a health issue when we have too much excess weight, right? The excess weight, or as we call it, obesity, crosses every line. It is, no one is, how do I say this?
It affects a lot of people.
It affects so many people.
Yeah.
It will cross boundaries. There's no bias. There's no boundaries. It will cross lines of sexes. It will cross the lines of ages. It crosses the lines of demographics, geography, socioeconomic statuses. So nobody cannot be affected by this. Let's put it that way. So we know that excess weight is an issue. We know that high blood pressure and diabetes can be consequential from this. We know that there are cancers that are associated with excess weight. We know that there are, I think, 236 medical syndromes or illnesses that we can also have from that, not to mention the psychosocial issues that you can get from excess weight. So excess weight, having obesity is clearly an issue. Why we know that excess weight is such an issue is because we've studied fat. We used to think that adipose or fat was just honestly this indolent, non-active yellow globules that we would find under our skin. And through research, we have honestly found that fat actually is highly active. It is one of the largest endocrine glands actually in our body, and it honestly hasn't gotten the respect that it deserves. There's no doubt about that. So being that it is this metabolic wonder, it can either work for you or it can work against you. And that is where excess fat actually comes into play as to being a problem. If you are actually in a good ratio with your body fat, then that can actually do some amazing things for you. It can cushion you, it can keep you warm, it can be used as energy stores. If you have too much fat or excess fat, then it actually works against you. It turns into a gland that actually shows a lot of dysfunction. It can suppress your immunity. What else can it do here? It can actually show an underlying inflammatory status. So we do get concerned as physicians that if there is excess weight, we're going to see the impact and the consequences of these diseases like hypertension and diabetes that will consequentially show their ugly heads if excess fat is there and there is too much of it.
Okay, so big health issue, and you mentioned
Yes.
the inflammatory component.
Correct.
One of the things that I think certainly the audience is interested in understanding is we've all had to deal with COVID, right, for quite some time now. And I think there's been some information in the news about maybe a link between obesity and COVID. So maybe, Dr. Frederiksen, we can ask you that question. What exactly is that link? Is it something that we should be concerned about?
So COVID is on all of our minds. Obviously, we've been living through this ordeal for the last year and a half. And so, but it is really relevant to talk about obesity and the state of COVID. Why? Because first of all, as Dr. Trippi was saying, obesity is an inflammatory process. What is COVID? It's also an inflammatory process. So together you have this storm, this tsunami essentially of issues that come up. And we have found in the last year and a half that patients who have obesity and develop COVID are 3 times as likely to be hospitalized as patients who are not obese. That's a big number. In terms of ICU stays, 1.5 times the risk. So if you suffer from obesity and you develop COVID, you're 1.5 times as likely to end up in the ICU as patients who do not suffer from obesity. So not only are we talking about and outcomes are poor. Obviously, if you're sick enough to be in the ICU, then you're very sick and your outcomes are going to be poor from COVID. So first of all, we're talking about terrible health outcomes, and then costs associated with that is astronomical, as we've seen, and so on. So So that's the effect in terms of what we're seeing with patients suffering from obesity as well as developing COVID. And what's happened in the last year and a half as well is when we've had this lockdown, we've had not patients, but individuals who are staying home who are gaining weight. So the average weight gain in the last year has been about 2 pounds per person per month, which is on average over the course of a year, 24 pounds. So, and that's an average. So you have people who are gaining more weight than that. And that also leads to obesity, right? So you're getting those people who maybe didn't have it, maybe they were in the overweight category, which we consider a body mass index between 25 and 30, obesity being above 30. Those people are also suffering and maybe moving into the obesity category. So then now they're at higher risk of complications from COVID. So there's this snowballing effect from the disease and COVID now adding to that we really need to address. And then finally, the last thing is that people have not been getting healthcare in the last year and a half. People have been delaying care. So for example, they've got uncontrolled hypertension and somebody is they're suffering from obesity. They're not getting care for that. Maybe their hypertension worsens. They don't want to go to the pharmacy to get their medication. They don't want to see the doctor. They don't want to go into the ER to get evaluated, whatever. And now they're coming in, they're sicker. So it's again, this other effect. So all these things are playing a role.
Gotcha. Well, that's, I mean, it's certainly, and I think there's a lot of information around, all these other, cardiometabolic diseases, diabetes, different things. But obesity sounds like certainly has a link with that or outcomes from COVID. I want to touch on something because it's interesting the language that you two are using to talk about obesity, and I think this concept of obesity as a disease is maybe somewhat new, to some people out there. But obviously we talk about cancer and diabetes, but I don't know if everybody sort of understands how obesity is a disease, and is it really, right? I mean, is it a disease, or is it just lifestyle choices that have led to this? What are your thoughts on that?
Yeah, so obesity is absolutely a disease. The American Medical Association, the World Health Organization, all the major medical and healthcare organizations in the world have recognized obesity as a disease. It's not a lifestyle choice. It is a cardiometabolic, metabolic, not just cardio, but a metabolic disease that is chronic and it's multifactorial. And that means different factors play into it, and different treatment modalities, which we'll get into later, play a role in this disease as well. So just as diabetes is a disease, obesity is also a disease. And then in terms of how do we diagnose, what is obesity? Scientifically, as I mentioned, body mass index is one measure. So it's not the best measure that we have, but it's a starting point. So for example, body mass index is your weight in kilograms over your height in meters squared. So it's a lot of mumbo jumbo, but essentially it's a measure of your weight over your height. And between 25 and 30, a BMI of 25 to 30 is considered for, other than Asians, it's considered overweight. And for a BMI of 30 and higher, that's considered obesity. Severe obesity is a BMI of 35 or higher. So for the Asian, the Asian population, BMI is actually a little bit lower. So if they have a BMI just slightly lower than what's the classic BMI cutoff, they're considered obese. They're much higher risk of metabolic disease, have a lower weight gain, let's say. So that's the definition, but yes, absolutely. And so as a disease, we treat this with medication. We treat it with certainly there's lifestyle intervention that one can do to help treat this disease, but that is not the only treatment option. Medications play a huge role. Even bariatric surgery is sometimes needed for patients who suffer from obesity and other diseases associated with that. So that's really how we have to look at it.
That's interesting, and I think that it starts to shift the perspective a little bit from this idea that it's your fault to there's something else going on, right? And actually, I want to go back to Dr. Trippi, because you mentioned that the disease doesn't discriminate. However, when it comes to weight, there is sort of this bias, I think, that we see, among our society. And I was hoping that maybe you could touch on that a little bit, talk to us a little bit about what do we mean by weight bias, and is there something that we can do as a community, and as employers to help address that issue?
Correct. Weight bias is something that absolutely does exist, no doubt. Weight bias refers to the act of discrimination or the negative attitudes or judgments or beliefs that's aimed at a person that just carries excess weight. And we do find that in many arenas. We can find that in the workplace where people that are overweight tend to be judged a little bit harder. There can be some disrespect. There can be a lower wage pay for people that are overweight. We can find this in schools in our adolescent population in terms of teenagers that are overweight. They can experience victimization and bullying. Even in healthcare, believe it or not, physicians aren't perfect. Not all physicians have the resources in their office to accommodate people that are overweight. Things as simple as the size of a gown for a patient or the size of a chair that can help accommodate with some sensitivity people that are overweight. So going back to the workplace and in terms of having a weight bias, when people experience that type of victimization, it leads to a lot of low morale. It leads to reductions in productivity. It leads to low retention rates for sure in the office. So there are discussions about how to eradicate weight bias. I think in all actuality, there's an education component to this for people out there to understand, like Dr. Frederiksen has mentioned, obesity is a disease. And it is not something that is easily treated, but we do know how to treat it. Education for the basic population of people would obviously be helpful to be more understanding of the disease itself. And clearly there's a lot of work to be done in terms of weight bias.
Oh, thank you for that. It sounds like it certainly hinders in some respects, actually being able to treat this, especially if you have physicians, that sometimes, have this, and whether unconscious or,
Correct.
conscious bias. So, but I want to actually bring in Justen into the conversation here, because we talked about, obesity is a disease, it's not necessarily people's fault. And I think we, whether personally or, knowing somebody, we've all kind of seen how difficult it is to lose weight and actually keep the weight off. So I'm just curious, I think the thought is, isn't it as just as simple as, exercising more, eating less? I mean, that's kind of the routine treatment, that's offered, but there seems to be some more things going on. But why is it so darn hard to lose weight and keep it off?
Well, it's a really good question, and one that I think is something that we have as a scientific community has understood now more than ever before, this phenomenon of weight loss followed by weight regain. And diet and exercise is an important foundational piece to that, but it's very rare that simply diet and exercise will be able to allow people with obesity to achieve their maximum weight loss goals and sustain and maintain those weight loss goals. And oftentimes, as the panelists have discussed, the person with obesity is blamed for not being able to achieve that. And there's thoughts that they're not dieting enough, they're not exercising enough. What we've come to understand over the last 10 years is that it indeed is not entire full responsibility of the patient. It's actually something that's happening within the body, and the brain, as a matter of fact, is actually defending itself from body weight loss. And it really adds layers of complexity for people that have committed to diet and exercise programs, but counteract this body's counterregulation. And I'll give you an example of that. So somebody that is 200 pounds and they're trying to lose weight and they start to lose weight. Well, in the brain, there's appetite signals and there's appetite suppressing signals. As the person starts to lose weight, these appetite signals accelerate. And so the patient starts to feel hungry. And there's the satiety signals that are suppressed. So the feeling of satiated or full is dulled. And then the amount of calories that you burn, that metabolic rate slows down as well. So the body rigorously defends that 200 pounds of weight. And so it adds a layer of complexity for people with obesity that have committed to diet and exercise and are just struggling to achieve this weight. And they oftentimes will regain the weight because of this hormonal fluctuation. I like to use the analogy of the thermostat in your home. You set it to 73 degrees. It's like the brain. It defends at 73 degrees. When you get too hot in your house, the air conditioning turns on. When you get too cold, the furnace turns on, but it protects that 73 degrees. The same thing happens in the physiology of the brain and the body. And so really the only mechanisms to overcome that is to talk to these two specialists and think about interventions that can be supplementary to diet and exercise, because it's going to require oftentimes additional interventions to overcome the physiology and biological change that are happening in the brain.
Very interesting. And I want to dig into that a little bit more, right? So you are both certified in obesity medicine, right? And I'm curious, and maybe I can start with Dr. Frederiksen. We talked about the health challenges of obesity. We just talked about how there's obviously more at play here, more that needs to address beyond, say, lifestyle intervention. So I guess the question to you would be, what is obesity medicine and how is it different from, wellness programs, right? I mean, they're very popular. I think they obviously serve a very important purpose. But how is obesity medicine different?
Yeah, it's a very important question. It comes up a lot. Obesity medicine is the practice of medicine. So it's a medical subspecialty. A lot of the practitioners in it are just usually starting in a primary care field, but not always, can be from any aspect of medicine or surgery. And it's the treatment of obesity as a disease with nutritional intervention, medication intervention, exercise or some activity intervention, and behavioral health. And one could potentially put the fifth pillar, which is bariatric surgery, but usually we don't do the surgery. We refer patients to bariatric surgery if patients are at that point. So for us, the four pillars are really those four pillars. And we use all of those modalities, and all of those are needed for 99% of the patients to achieve their goals and to keep the weight off. It's not just a unimodal disease. It is a multifactorial, multimodal approach to treating the disease. Wellness programs, on the other hand, are not to be diminished. I mean, probably a third of people who are suffering from overweight or obesity do get benefit from it and do lose some weight, but these are typically non-medical programs that maybe provide a coupon for the gym so that you're more likely to go to the gym and get some exercise, or you are visiting with a dietitian so you get some ideas about how to eat better, which are all important, but they don't necessarily treat the weight and help you keep the weight off.
Gotcha. Okay. That is clear. And I was going to ask you about bariatric surgery, but I see kind of how that fits in sort of, smaller segment, of those that, kind of run through the wellness program, the medical weight management, and then, eventually, if that doesn't work, you get to that state. So I want to go to Dr. Trippi, because to get a little bit more specific, right, you run multiple medical weight management clinics. So I was hoping that you could tell us a little bit about your program and, is it hard to do? I mean, what does it entail? Just so people can get some specificity around that.
In order to run a practice like that, I clearly felt like I had to have a passion for it, number one, so that you honestly can have compassion for your patients. Because honestly, this is probably one of the most raw places on earth to be treating patients. I mean, you talk about tearing off scabs for these people.
Yeah.
It's like opening up a can of shame for a lot of people, and they want help. So to even come through the door and ask for help is huge. It's a huge leap. My office practice, every time a patient comes into the office, they're going to be seen by a provider. And their very first appointment is pretty thorough, I would have to say. They're going to get a full history and physical. We're going to talk about their social history, their lifestyle, their past medical history, their medication lists. we're looking for anything that we can possibly change on these patients. They're going to get lab work done. They're going to get an EKG done. It's a very thorough first visit. On their follow-up visits, well, let me go back to the first-time visits. At their first-time visit, we are looking to consider where are we going to make their behavioral modification changes, nutritionally, what are we going to help them with to make them a little bit more healthy. We'll also talk about medication therapy for these patients, although not everybody ends up on medication therapy. When the patients come back for their follow-up visits, we always scale these patients and take measurements so that we have something to measure improvement by. It's a wonderful practice. There's a lot of patients coming in, and we've had no complaints yet.
Yeah. Sounds great. Well, that's good. That's good. So, well, I want to actually touch on, just measures of success, right?
Right.
Goals and expectations. And actually, I wanted to bring Justen in again on this one, if you don't mind. So we talked about, all the different comorbidities, and we were talking earlier that I think there's upwards of 60 different comorbidities that are associated with obesity, osteoarthritis, type 2 diabetes, cardiovascular disease, sleep apnea, and there's so many different things, right? But just out of curiosity, I think, people probably are interested in knowing how much weight is actually required to have an impact on overall health. I mean, I think a lot of people think, do I have to just lose all this weight, all at once, or how does that work? So can you speak to that a little bit?
Yeah, it's a good question. And I think to start, any amount of weight loss is beneficial, any amount of weight loss, and should be commended and complimented because it is challenging, as we just described. And the more weight that you can lose safely and successfully sustain that weight loss, the better the health outcomes that have been described by these specialists in the panel here. Typically, what we find from evaluation of the literature over extended periods of time is that when people with obesity are able to achieve between 3 and 5% weight loss, they can see immediate improvements in their blood pressure, in their blood glucose. As they start to achieve additional categorical weight loss goals, so they get to see 10% weight loss, you start to see additional health outcome benefits. For somebody with asthma or respiratory disorders, they actually see improvements. We talked about the inflammation component of adipose tissue, and asthma is an inflammatory disease, COPD is inflammatory conditions. And as you start to achieve even additional weight loss, so 15% or more, you can actually see reversion or prevention of type 2 diabetes, or even newly diagnosed type 2 diabetic patients can actually go back and have normal glycemia, reversion of type 2 diabetes, reductions in cardiovascular related risk factors and events, reductions in strokes and heart attacks and mortality, improvements in heart failure. So safely losing weight and doing so in a way that you can achieve maximum weight loss and sustain that weight loss, the more weight you're able to achieve, the better health outcomes and the better health benefits you will have as a patient.
Makes perfect sense. Thank you for that. And I actually, to segue a little bit, I wanted to go to Dr. Frederiksen real quick, because I think it makes sense. This sort of idea of how can we influence body weight, right? You talked about medications, you talked about behavioral intervention. You kind of wanted to double click on the behavioral intervention piece maybe, and just get your thoughts on, what are, beyond just eating less, exercising more, right? Are there any other ways that people can influence body weight? We hear a lot about stress, we hear about sleep. I mean, any comments on that?
Yeah, all of those are important. So we do know that, as we've said many times, obesity is an inflammatory state. Stress releases inflammatory hormones, and the more stress that we experience, the more we again set off the sort of tsunami pathway of higher inflammatory levels, and stress also certainly leads to eating more, sleeping poorly, and so on. And we know that, and perhaps getting less exercise. So one of the pillars that I talked about, behavioral health, which I focus on when I see a patient right away, is are you seeing someone for stress reduction, or are you seeing a behavioral health therapist, or do you have some support group? What are you doing on that side of the one, on that, with that pillar, to address what's going, and that might mean immediately getting someone in with a therapist. They've never thought about seeing a therapist before, some kind of support, and it doesn't need to be a formal psychiatrist or a psychologist, but some kind of therapist who they feel comfortable with. But maybe in fact, they do need a psychiatrist. Maybe they need to adjust medications they've been on, or they're suffering from severe depression, and so they're not sleeping well, they're having high stress levels. That may need to be addressed through medication. So there are a lot of different components within that pillar of behavioral health. Sleep is huge, not only in sleep in terms of what the outcome of obesity can be, meaning sleep apnea can develop as a result of obesity, but also poor sleep can definitely lead to weight gain in terms of eating poorly, higher levels of cravings for fast food and high starchy foods, which lead to weight gain. And so all of that is important.
So nice holistic approach, and there's a lot of things that we can do beyond just, what we're eating and how much we're exercising, which is good to know. So I kind of wanted to flip it over to Dr. Trippi, because, we have talked a little bit about the interventions, the things that we can do, right, to address obesity. And I know there are medical treatment guidelines for other diseases, and if obesity is a disease, I'm just curious, are there sort of treatment guidelines out there that exist for treating this disease? And it sounds like you probably follow those if they do. But.
Yes, we do. We have guidelines, and I think that's an important word to use because it's a guideline. It's not a mandate. It's not a rule that we have set by different medical societies that we belong to. And these guidelines are derived from clinicians that practice in the field. So we try to set a standard of care on our guidelines. We are looking for patients. When we say guidelines, let's talk about the guidelines of pharmaceutical or medication therapy. There are specific guidelines for that. There are, in terms of body fat measurements, we're looking for patients that are potentially 25 to 30% in body fat. We can look at measurements of their waist, which is extremely important for cardiac reasons. So for instance, a man greater than 40 inches around the waist, a female greater than 35 inches. We can even look at lab values. So anybody that has a high cholesterol, triglyceride, we can even look at a blood pressure as a guide. If people meet a certain amount of those parameters, then they might meet criteria to be on medication therapy. We have other guidelines that are beyond pharmaceutical help. We have guidelines just in terms of treating these patients and following algorithms to know how we would follow a workup on this patient from beginning to end. So there are different kinds of guidelines. The biggest guidelines that we follow for obesity are going to be the pharmaceutical guidelines, because you certainly don't want somebody walking through the door with a BMI of 18 and asking to lose weight and thinking that it would be appropriate to put them on a medication.
Yeah.
So we try to follow these guidelines because the research, again, follows that. This is evidence-based medicine, and we know that these medications work if it's put on the right population of people.
Makes perfect sense. So, it's good that, it sounds like, obviously there's a whole world of obesity medicine and, obesity as a disease, and you guys are actively involved in treating that. So this may be new to some folks, but one of the things I wanted to sort of shift gears on is we've talked about obesity as a disease. We've talked about what you all do to address this, but I kind of wanted to talk a little bit about what individuals and employers can actually do, just to start, right? So maybe with Dr. Frederiksen, obviously you built obesity management programs and worked with employers, in the past. So, I'm just kind of curious if you can speak to that a little bit, and then also, are there any notable examples of you working with employers or even health systems with these programs?
So yeah, so I've this has been my passion to develop these programs, and I've developed 2 successful obesity medicine programs. One was with a group of bariatric surgeons. They were providing the surgical care, obviously, but they really wanted a medical component for patients who either didn't qualify for bariatric surgery, needed help to lose weight before bariatric surgery, or change their mind, or were developing weight regain, and so then they needed some help from the medical side. So that was a great success, and I developed that program in Indiana, and within a year we had a second site, and it was quite exciting. From the employer side, I think the health system was very excited about it as well, because their employees did better. Their employees felt better. They were happy about the program. We've seen over and again statistics that employees are having fewer sick days. They're more productive at work if they're feeling better. So all these factors played a role in how the program was perceived and was successful. And in this area at Renown, for the last 4 years, I've had a program which was not with bariatric surgeons, but with medical weight management. And we have had dietitians in the program, a lot of success, a lot of employees from that system, but from other systems, and saw similarly a lot of success with happier, healthier employees and less stressed employees. And so it's been great. I think the biggest thing from the employer side is to really see what the benefits are, and to have, if you're not at senior management level, to get senior management involved, engaged in this process, and realizing how important it is for their organization and for their employees.
Yeah, I was going to ask, what is a good place to start? Because it seems like such a,
Yeah.
big
Well, I
problem.
think, yeah, so just sort of going back to the second part of the question, which is using examples from other employers, so and other health systems. So for example, I heard recently at Weill Cornell, which is New York Presbyterian in New York City. It's a big medical school, medical center. Their obesity medicine program is the fastest growing program in the entire system. So of all their renal, pulmonology, cardiology, the list goes on of all their medical programs, the obesity medicine program is growing the fastest. Why? Because we need to be addressing this disease, and they're doing it successfully, and the upper management is recognizing that. And so that's really a great example. But there are other ones. Mass General's program is growing, Cleveland Clinic, Stanford. So you look at these big centers, if they're doing it, there's a
Right.
reason why they're doing it.
Makes sense.
And so we need to be listening to that.
Got it. Well, and I want to bring Dr. Trippi into the same kind of discussion too, because, obviously I know you work with several employers in this state in particular. And so, when you start working with these employers, and for those that don't have necessarily an obesity management program in place, what is a good place to start? What are some of the things that you sort of talk about, with these employers?
So it's an interesting concept, because when you look at the American worker, there's been a real conversion of the type of work. It's gone from manual labor to a lot of desk jobs, and people spend more time at work than ever before. So you have to consider that even though that could be looked at as a negative, where they're behind a desk for very long hours in the day, there's this potential influence that being at work and that your employers will have at making changes for people that work there. There's a huge potential influence to have a positive consequence from this. So in terms of having your workplace and the employer be involved in a person's weight loss journey, that's really important. There's prevention and treatment. At the very lowest levels, prevention, there's simplistic things that people can do at the workplace and that their employers can do to help out. Simple things as healthier foods in the cafeteria, healthier foods in the vending machines, getting people up and walking around within their 12-hour day behind the desk.
Yeah.
The question employers have to ask themselves, and this is what we ask our employers when we're looking at contracts, self-funded contracts, is how does the employer identify the riskiest of the risky in their employee population? And how do they engage their employees to become healthier. Because there is some ownership in having that person there all day long, working for 12 hours. And again, that potential influence, there's amazing opportunities in having that potential to help treat their patients treat their employees.
So just identifying those populations.
Absolutely
is a great place to
identifying.
start. So,
Yes.
and one last question, a couple last questions, and we're almost out of time, but one thing I'll bring Justen in on this, and I'm curious about is, all of these other sort of chronic diseases, diabetes, hypertension, I mean, it's sort of, these employers, it's a standard sort of thing to, provide treatment, right, for these diseases. But obesity is one where, sometimes employers provide that, sometimes they don't. But I'm just curious, Justen, who decides if obesity treatment is a covered benefit, among an employer?
Yeah, it's a good point that you bring forward, because as you just described, other chronic diseases like diabetes, they have treatment options available in the benefits package that the insurance carrier provides to the employer, and they're standard benefits. So they have medications that they can use, and they have coverage for different interventions that they are standard. Obesity, even though it is a complex chronic disease, a defined chronic disease, as Dr. Frederiksen had described earlier, with AMA recommendation and other professional societies recognizing obesity as a chronic disease, oftentimes those obesity treatments and the medical management of obesity is not included as a standard benefit. So it's required for the employees to ask their employer, their HR benefits consultant, their employee benefits coordinators, to look at the insurance carrier that they have and perhaps look at the benefits package to make sure that obesity treatment is included. If it's not, oftentimes it's a very simple process where the employer would just have to ask the insurance carrier to allow them to have access to these treatments and utilize these treatments for these patients. I know the Chamber of Commerce, I think, has resources for employers that perhaps are seeking to understand what type of questions they should ask their insurance carrier and vice versa. But the employer is the good place to start with the HR benefits and employee benefits coordinators to help navigate that.
Sounds good. Thank you for that. Well, we're almost out of time, but I wanted to get some closing thoughts. Obviously, we've got an audience at home and audience here as well. So some closing thoughts from each of you, and then how can people find you and get more information, right? So maybe we can start with Dr. Frederiksen and kind of go down the line. But, yeah.
So I'm just really happy to be part of this panel. I think it's such an important discussion to have. We really need to recognize what obesity is and how prevalent it is. I mean, essentially in 2030, half of the US population of adults will be suffering from obesity. That's not including overweight, that is just obesity. So if you include overweight, 75% of the population is touched by this issue. This is a disease that affects all of us in some way or the other. We've talked about how COVID has affected us in some fashion, but obesity is much more prevalent and is a chronic disease. So we need to really be addressing it. And I'm so glad that we had the chance to do that here. And in terms of how to find me, Justen can always find me. And so you can always reach out to him. I will be opening a new venture here shortly in this area. So I'll be putting out information about that shortly as well. So
we're very excited about that. So thank you. Great.
Right. Thank you very much for having me.
Yeah.
COVID did bring things to light, no doubt. It certainly brought obesity to a recognition that we didn't have. And obesity pandemic has been here longer than COVID for sure. So I think the one thing I would love to take from this, and I'd love everybody to take from this, is that when we look at treating obesity, we need to really consider in the workplace how we can help these patients. Physicians are advocates already, and we have already identified that obesity was an issue. Where we need support is on different levels and on different platforms that we can't exactly reach ourselves as physicians. We can do everything in our office, but there are things that can be done in the workplace to help people lose weight. But we need the support to be able to have employees have access to us and have access to the medications that we know by research are going to help. And so if we could just get that accomplished, I think we could actually make a big dent in obesity if we had that kind of support from employers and different platforms.
Good deal. Thank you for sharing.
I'll just close by thanking the chamber and my esteemed colleagues for allowing me to join the panel. I too, affirm exactly what's already been shared. Obesity is a complex chronic disease that requires kind of a multifactorial approach to management, and utilizing specialists like this, having employers recognize the impact it has on their employees and themselves. Financially, the data supports that. Unfortunately, people with obesity and higher BMIs have a higher cost to the employer, higher workers' compensation claims. Safety is an issue for these people with obesity. And then productivity, et cetera, is involved. And it takes all of us, community, healthcare professionals, all of us to really address obesity and to empower providers within the landscape, recognition of people that are struggling with this complex chronic disease, and the fact that we all can play a role in being involved in helping to support improvement in the lives of people with obesity.
Perfect. Well, I think that's a great place to close. So I want to thank you all for being on this panel, and hopefully you all at home and here in the audience took away a few things that maybe you didn't know about this very prevalent disease. But thank you for joining us, and we'll end it there. So thanks, Christine.
All right, thanks everyone.